All right, yeah, we'll kick it off then. Thanks all for joining us, those live and those also tuning in after the fact via YouTube. We're lucky to have StationMD joining us for our second session of our webinar series, looking at innovative technology that can support individuals with intellectual and developmental disabilities. Dr. Trivedi, a co-founder of StationMD, and a board certified emergency physician, has been in practice for over 20 years, and been very instrumental in helping Station MD achieve its mission of improving the quality of care for individuals with intellectual and developmental disabilities. He is a national recognized speaker and a thought leader on the use of technology and telehealth solutions to positively impact individuals' medical care and foster independence. We're very lucky to have Dr. Trivedi with us, and so looking forward to hearing your presentation. And without further ado, I'll pass it on to you. So thanks again.
Thanks, AJ. Can you hear me okay? Is that okay? Great, great. Well, first of all, I want to thank AJ and AAIDD for having me. Really appreciate the opportunity. I'm going to be talking a little bit about what I think is really a game changer for the individual that we're all supporting and the disability community in general. I am talking about essentially bringing the quality of healthcare to individuals with IDD to another level, and a level, frankly, that I think it should be at. So, without further ado, we can go to the next slide. Um, should flip. Great. So, just in full disclosure, I am one of the co-founders of StationMD and part owner. This talk is meant to be more of a high-level discussion about the use of telehealth and technology, not about specifically StationMD, but a lot of what my experience comes from is from what I did with this company. But this is by no means supposed to be pushing one or the other. I think that this is a game-changing and disruptive technology, regardless of who is providing. I think it should be given to the individual so that ultimately their quality of care is elevated. Next slide. With that, just to give you a little bit of background on myself and the organization, I'm an emergency medicine physician by training, and I founded the organization, co-founded with several other physicians, partly because of my connection to the community, some family relations, and also because of what I and my co-founders witnessed. And for many of you on this call probably are familiar with is that when there is no other recourse, individuals get sent to the ER for their health care. There would be seen by emergency medicine physicians who really have a very cursory understanding of this population. I feel very comfortable saying that because I was one of those doctors. There's very little in medical schools and medical education taught to individual physicians in their training about individuals with IDD, and we all know that's a spectrum of disorders. In fact, I was at a conference in Pennsylvania just this week or last week, and some medical students are in the process. I think it was University of Penn. It might have been Penn State. We're doing a study about it, and they found that in the 4 years of medical school, 11 minutes total are devoted to the education of medical students about individuals with IDD. So they don't really understand, you can imagine, the clinical nuances of this population. And then by default, you're going to the ER, which is not the place that individuals should be going. So I do believe that when you're providing telehealth to individuals or care in general to individuals with IDD, you need to be educated. And all of our clinicians go through a specialized curriculum and training. I don't know the exact number, but it's more than 11 minutes. And we spend a lot of time. We do monthly grand rounds with this population. Again, I think the quality of care that we provide individuals is due on our experience, is based on our experience and learning from each other. And that's how we learn as clinicians. We share best practices. We share how we could improve on the care. And just to give you a sense of last year, in my organization, we did over, I think, 40,000 virtual visits just with individuals with IDD. So I think that's important if you're lucky enough in your area to have a group that's focused on this population solely. It's pretty rare, but if you are, that's great. But a lot of times the breadth and depth of the practice is maybe a few people with IDD, and sometimes it's really hard, especially when you age out of pediatrics, to find a physician or a clinician that will take on an adult. So, next slide. So I do also think, as an AAIDD. There's a lot of other organizations that I think it's important and incumbent on all of us to participate in those. We speak at a lot of those. I go to a lot of these conferences, and the more we consider ourselves advocates and spreading the word, that's really the only way that things are going to change in terms of services delivered to individuals, getting more education in medical schools. So I just would implore people to be contributing to their local and national organizations. Next slide. So, why do individuals with IDD tend to use the ER more frequently than others? And outside of their underlying intellectual developmental disabilities, they have other comorbidities. They are complex. They may have pulmonary issues, GI issues, behavioral issues, and even if they have a primary care doctor, it's not like that primary care doctor is available all the time. They may not have the same technology that we, for example, do in to visualize someone, and by default, they send the individual to the ER urgent care. There's an access issue for individuals with IDD, and it's not relegated just to rural areas or urban areas. In general, getting access to quality health care is a major issue. And again, by default, people get sent to the ER or urgent care. I put in here regulatory requirements. Many individuals are served by provider agencies and organizations, and these agencies and organizations are tasked with regulations. These are well-intentioned regulations um, with unintended consequences, where if something happens, they have to be seen right away or seen by a doctor or nurse. And oftentimes, the only recourse is, without telehealth, is to go out to an ER or urgent care, and it is a burden. Our goal in the use of telehealth is to treat the individual in the least disruptive, most stable environment, and that is their home setting. Next slide. So I put in this a slide. I think this is from 2002. It was a study about physicians' attitudes towards people with disabilities, and it's very disheartening if you read the deeper article. But a lot of doctors don't feel comfortable taking care of people with disabilities. A lot of it is because of what I mentioned already, is their lack of training and understanding of the clinical care. But a lot of it is also they have a bias, just like the rest of the population, and they are uncomfortable caring for this population. So you can imagine if you surveyed a bunch of doctors and said, who are you comfortable taking people with colds or people with heart failure, and there would be an uprising. And yet, this is something that is very common in the medical community, where physicians anonymously say that they are not comfortable. They don't feel comfortable carrying this for this population. And that's just another reason that we should be, it's important that we get the word out on what the challenges are for individuals, what the challenges are for the people that support them, and how can we improve the quality of the care that they receive. Next slide. So, the emergency room is a difficult place to be in for anyone. This is a real picture of an emergency department, and you can imagine laying in a hallway is miserable for anyone, but for someone who is nonverbal or has sensory issues, especially traumatic. I always call it the trauma of transport, just getting individual there. It's frightening, and is not only frightening, but it is disruptive. In my many years in the ER, I've had individuals come simply for a med refill or a simple issue, and they wait for 6 hours in a busy, chaotic emergency department, in a hallway maybe, and it is not the place for many, many things. And I think that will be pretty evident by the end of this. I hope it is by the end of this conversation that there are other alternatives instead of going to an ER. It's disruptive, it's challenging, you're going to see a clinician who most likely doesn't really understand the nuances of what your needs are, and oftentimes takes days or weeks to stabilize after going and spending a traumatic 10, 12-hour visit in the ER. Next slide. So you have this combination of, trauma to the individual, also to whoever's supporting it, whether it's a DSP or family member. It's very disruptive, and it is suboptimal care. Again, you're not seeing someone who is specially trained necessarily to understand your clinical needs, and it is expensive. Studies have shown that individuals get overly tested, more likely to get admitted to the hospital with a similar diagnosis than someone without a disability. And of course, it's expensive because hospitalizations are expensive, ER visits are expensive. So I do think there is a better way. I don't oftentimes look at, most of the time, I don't look at a telehealth solution with specially trained clinicians as a substitute. I look at it as superior care to going to an ER that's chaotic with 25, 30 other people that the doctor is caring for, and they don't really understand your needs. So, next slide. So, if we switch our gears to telehealth, I think if there has been any silver lining to the pandemic, I think it's that telehealth has proven itself for many conditions, not everything, as a viable means of delivering healthcare. And you yourself, you may have telehealth as an option through your own health plan. I would argue the value of telehealth for individuals with IDD is even greater in many instances because of what I mentioned in terms of trying to reach a specially trained clinician who really understands your clinical and non-clinical needs. Transportation, just arranging transportation is challenging for many people just to get to an urgent care doctor's office or an ER. Oftentimes, the population we serve rely on someone else to help support them, whether it's family or a direct support professional. And we all know that there is a staffing crisis. So we worked in some homes prior to us working in a group home. And if one individual out of a group home or four or five went to the ER, everyone got in the van and went because they're so short staffed. So for that and other reasons, I think the value of telemedicine is tremendous in many instances for this population. Next slide. So on the left, I have the problem, and right, I have a solution of how telehealth and telemedicine can help. The access issue, getting access to quality healthcare. With telehealth, there are no geographic impediments. We can reach individuals using telemedicine as long as there's a Wi-Fi signal or a cell signal. Now, that's not always the case, but that's a whole nother conversation. But I do think that we can expand access. The suboptimal care that I think this population receives, I think it's important to connect with doctors that have specialized training. I think it's important to connect with physicians or clinicians who have access to the individual's medical records. In our practice, for example, we're able to see the individual's past medical history, allergies, et cetera. Um, and it's a personalized approach in the individual's own environment. And I think that's something that I can't emphasize enough. Um, Many of the individuals we care for, once they're taken out of their safety and comfort of their own home, they decompensate. Um, I mean, anyone would decompensate waiting in ER for 6 hours, but you can imagine for someone who is sensitive to that, it's traumatic. So we care for an individual and resolve their issue in 20, 30 minutes, something that would have taken 6 hours and a day to recover. So it is a personalized approach. I do think any telehealth solution needs to be available at all hours, 24 hours a day, 7 days a week. And I think that there needs to be documentation of all these, where after the interaction, documentation is sent to the caregivers, it's sent to the primary care doc, and the care is coordinated. So it's not, there's follow up, there's a continuum of care, and then again, there's coordination of that care. Maybe that individual doesn't need to be seen by their doctor now, but they can be seen later in the week at a more convenient time instead of like Wednesday at midnight. So we do that, and I think it's important to share that, obviously in a HIPAA compliant fashion. But there's a lot of regulations that agencies face, and I think having a telehealth option can really help kind of tick those regulatory boxes and make sure that a physician or clinician is there. Next slide. So I do want to emphasize at least what we do, and I think for any telehealth solution, you should be able to address non-emergent cases. If someone needs a refill, constipation in our population turns into bowel obstruction when it's not addressed. UTI can turn into urosepsis. So these things should be there. One thing that I didn't anticipate when I started doing this several years ago is the amount of support that we are providing direct support professionals. We have amazing DSPs who are wage earners. We're asking them to be chefs, and we're asking them to be drivers and coaches and teachers, helping individuals with their activities of daily living. I don't think they need to be or should be clinical and have to have that other responsibility on them. They should have a resource, and I think telehealth provides that resource and really helps support DSPs. And I'm sure many of you on this call know that there is a staffing crisis in this country, and I think that to have at least one thing less on the table will really help support that population. Next slide. this is just a screenshot of our portal, which we call Station Connect. But I think it's important when a clinician evaluates someone that they have access to the health record. Um, I've given a story. I give this story often times, and it resonates with people who work with this population. For me in the ER, what happened typically is an individual would come to the ER with a DSP who may or may not know that individual, and then they would hand me that binder that everyone has. It looks like a phone book, and like I never read it. No one reads it. You don't know where to find information. Things are like scribbled, and so by default, I end up doing tests and probably over testing and probably not for the right reason. As opposed to having a repository or an area where I can look, this is a past behavior, this is a past medical problems. Hey, they were just in the hospital last month for a bowel obstruction. So it does paint a better picture. And I think there also needs a place where we collect data. We've had over 100,000 encounters, and from that data, we can derive best practices, and that's how you change policy. Anecdotally, you can't say, well, I think this is something good. You have to show to the policy people, like, hey, look, here's the data. This is what happens when you do this. And A leads to B leads to C. And frankly, it's important to show that not just for better outcomes, but also to prove the ROI, the return on the investment, because there are a lot of great ideas in healthcare, but we have to prove it, and that's how it'll change. That's how policy will change. Next slide. So I just want to talk a little bit of outcomes because I think it's important. We can go to the next slide. At least with our work using telehealth, 93% of the time that we get a call, we are able to keep an individual in their home setting, meaning we don't need to send them out to an ER, which is pretty huge if you think about it. Meaning 9 out of 10 times when someone calls, we're able to resolve that issue. Now, the biggest impact of that is for the individual, and they're not going to ER. They're getting to do what they want to do. The quality of life for them and their DSP is way better. But you can also imagine the financial implications, right? I mean, saving an ER visit or an urgent care visit, these things are not cheap. And so that's how I think you can justify this to whether it's a payer, whatever that payer is to really look and evaluate this, number one, from a quality perspective and quality of life, but also from a financial perspective. Next slide. The next slide has some examples, I think, of what, and it may be a little small to see, but these are the reasons we get called. And the light blue are the ones that the ER visit is avoided or urgent care, and they're treated in place. The dark blue are the ones we send out. But these are probably common to you, those of you who are in this population or care for individuals here. Cough, fever, fall, COVID, abdominal pain, conjunctivitis, UTI. A lot of these we resolve, and I will mention that any of these that we do send out to the ER urgent care, and I think this should be part of any telehealth solution, is that we will call in advance. So in lieu of that binder, it would be a doctor calling another doctor saying, hey, I am sending this individual for this reason, for a test that they need, an ultrasound. I want to make sure there's no clot. And it really is the gold standard. For me as a physician, it's always welcome when another clinician calls me and says, hey, this is why I'm sending this individual. Um, Oftentimes I'll let them know, like, try not to make them wait in the waiting room forever. They will decompensate. It really does expedite the care oftentimes, and also eliminates a lot of unnecessary testing, and also allows that individual to go back into the community because they know that someone's going to follow up on them. They know that they're not just sending them out into the ether, and who knows, anyone is going to check on their tests. Is their antibiotic going to get filled? So I think that's critical. And that again is another thing that I didn't anticipate when I started, how important that was to have doctor to doctor or clinician to clinician discussion. So next slide. So we did partner with an organization. Can you guys hear me? There's a little feedback. Sorry. We did partner with an organization to survey individuals. These are individuals that are nonverbal, some individuals with other intellectual disabilities. I think it's called AbleLink that helped us with the survey, and they were overwhelmingly happy with it, as were DSPs and caregivers. Those numbers aren't as great, but the ones that didn't they just didn't fill out the survey. So, but overall, people were really happy, and I think that's important. We have to ask the individual. You know, we talk about person-centered planning and caring and about what the individual wants. So we should ask them. And sometimes we have to use a non-traditional approach on asking them. So I think that's important. Next slide. And I did want to briefly touch on the agencies. These are agencies that are tasked with caring for individuals. They found not just an ROI about using StationMD, for example, but there's a cost savings because, again, they're avoiding ER visits, avoiding overtime. And I can share these slides with you if you want. I think the next slide is just another agency slide that found, we can go to the next slide. They also were a New York-based provider agency. And I only bring these up because, you know, in the reality of healthcare, um, we can spend a fortune, and there's no limit to how much you can spend on anything and everything. But the way policies get changed and the way we can really drive change is if we show that there are things are at least budget neutral or that there's an ROI, and everyone wants to provide good care. But to me, this is a sort of situation where you're providing better care and saving money because the ER is not the place where individuals should be going. I think that was the last slide. I'm not positive. Yeah, that was just a QR code. You can ignore that. That just goes to our website. Be happy to go there to get more of a visualization. But um, I would say that, you know, the value of telehealth, again, for this population is huge. I think that in this day and age, there's no reason that an individual with IDD should be going to an ER or urgent care or even their doctor's office if they have something that can be handled using telehealth. I don't look at it as a substitute. I look at it as superior care. I think that we have shown the data and I also think that it is a way to bring a specialized clinician who really understands the needs of this population to the individual. Again, if you're lucky enough to have a great doctor who really understands your needs, or a great clinic that has IDD trained, developmental medicine trained clinicians, wonderful. But that is the exception rather than the norm. The use of telehealth is a way to actually bridge that gap. Um, and I also think that you have to understand the limitations. I don't want to give the impression that it is a cure-all. There's a lot of things that cannot be done via telehealth. You know, CAT scans and suturing and things like that. Well, not yet, I should say. The technology is improving, but I think that there is a place for it, and I think that it is ultimately, um, if we look at what's best for the individual and the families that support them, that's really where our goal and our focus should be. So thanks. I'm happy to take questions or AJ, if you had any comments. But I think we can also share this video, I mean, this slide deck if you want, but happy to address any questions that may arise.
Yeah, thanks so much. We'll leave it open here for some questions if folks want to either raise your virtual hand or shoot it in the chat, and we'll see if there's any questions. But otherwise, really appreciate you taking the time this evening.
Sure, sure. I do want to say that I think it is important to make sure the solution is easy to use. Just so you know, we don't require any fancy equipment. What you do need is a smartphone or tablet or iPad, and then it's just an app that you download. But I think that's important that we don't make it overly cumbersome and challenging. Someone who's never done it before can jump on like right now and do it, and I think that's critical because the more challenging you make it to connect and the technology-based issues, the more less people will use it. So yeah. I think there is a question here. Can you tell us more about the platform you use? Was it built in-house? Yeah, so the platform that we use to connect is this. It's Zoom. It's a HIPAA compliant Zoom platform. So it's really easy to use, and we didn't build Zoom. I wish I would have built Zoom. But so it's based off of Zoom, and it's just a compliant Zoom platform that we use to visualize someone. Now, the other platform we did build, which is called Station Connect, where we keep everything in there, the doctor's notes. We also built a back-end system for our doctors to write the notes, to send the notes and the documentation to the support staff, all of that, to send those notes also to the primary care doc. But the actual platform of visualizing someone is a Zoom platform. In addition to that Zoom platform, what's nice is we can see someone and I can send a link, for example, to their guardian who may be in another county or city or state. So that way, we can all talk, or I can send it to a nurse, whoever wants it. So, yeah. And the question is, can you explain more now that you navigate different rules and regulations that each state might have? Yeah, great question. So, right now, I'll say, in each state, it's unique how we operate. I hope I don't confuse people, but so the way we work in some states is we're on the waiver, meaning, for example, in Missouri, just got started in Pennsylvania, Tennessee, and then some others are on the horizon, Ohio, I hope, where it is a waiver covered service. So anyone that's on the waiver, it just gets added to their state plan, and then that's how the service is provided. We try to bill Medicaid for the actual Medicaid eligible visits that count, but that alone isn't sufficient, like a fee for service world. So that's one. Number two, we work directly with provider agencies in states that, like for example, in Illinois, provider agencies pay us a per member per month to care for the individuals, and that's another mechanism of that ability to evaluate and see someone using telehealth. And then finally, we do work a little bit with some managed care organizations where they provide the service as part of their offerings to individuals. That's not in many places because a lot of places, those health benefits are carved out of managed care. And then finally, sometimes states will fund us as a pilot. For example, in Ohio, they are covering 5,000 individuals and they fund the services with the hope of showing the data, proving the concept, and then creating a waiver or something out of it. So, and in each state, we have to be licensed. We have to have all of our Medicaid paperwork together. So, and that's on us, but we can't just see someone in a state that we're not licensed. It's just that those are some of the other rules and regs that we have that are we have to abide by, and that's regardless if it's telehealth or in person. Um, is StationMD available in all states, or where can folks access the service? No, we are not in all states. We are in operational in 22 states right now. If you go to our website, we may have that exact list, or you can just email us from there. But no, short answer is we are not. Part of that is the previous question is we have to be licensed in that state, and for us to get licensed in the state, depending on the state, it's a process. It takes time. It's obviously very expensive. So we just have to make sure that we can actually cover those costs and also get our docs and our APPs licensed in there. And some states it takes 2 months. Some states it takes 12 months. It's really all over the map. But we are in 22 states that we're operating.
Great. Well, from there, I think we're good to wrap it up. Again, really appreciate your time. This was very informative, and for those folks looking forward to our next and third webinar installment, will be coming up here in 3 weeks, so not quite a month away. But we're partnering with AbleLink to put on that third one and to hear a little bit about what they are doing, as we heard Dr. Trivedi mention them earlier this evening. And so looking forward to that one and for seeing some of you folks in the future. So again, thank you and have a good evening, everyone.
Thanks. Thank you. Bye bye.